can start the discussion, Prof.
Okay, Dr. Risa.
Yes, Prof.
Okay, so who is presenting the first patient?
Me, Prof. I will
Okay.
present the first case. Let me share.
Hey, Dr. Yeti. Good morning.
Good
Good
morning.
afternoon.
Good afternoon, Prof. How are you? Fine?
I'm good, thank you.
Yeah. Actually, I
Okay.
have a schedule on polyclinic this afternoon, but okay, I will join. I have joined this discussion via Zoom.
Oh, much appreciated. Then maybe let's start. This is patient
AKA, Prof.
AKA. Okay, also known as. Okay, good.
Adnan. Okay, Prof. Good afternoon, everyone. This afternoon I will present the case AKA age 9 years 9 months old boy. Admission date at November 28, 2024, and date of diagnosis is May 12, 2021, and date of start therapy. The first chemotherapy is on May 28, 2021, and date of finish therapy in November 24, 2023.
Okay. Oh, stop. Is there something that's remarkable about the dates?
From the diagnosis,
Yes.
to start the therapy is in 18 days from.
Oh, that's well, a little bit longish, but
Yes, Prof.
acceptable. But what about the date of the start therapy and date of finish therapy?
Is around uh about almost 2 years, Prof.
Almost
More
two.
than 2 years.
Yeah, more than 2 years. So, and what is the length of the chemotherapy?
Yes, Prof.
For ALL? 102 weeks was it. So, how many weeks is it until November 24, 23? More than 102. I didn't compute it exactly, but it is
More than
June, July, August, September,
September, October,
October, November.
to half.
Almost half a year delay.
Yes, Prof.
So that's a first clue. This boy was treated for ALL, and the finish of his treatment was about 6 months, 24 weeks later than it should have been. So
Yes,
what
Prof.
happened?
Actually, it's because of the regulation at the time, Prof. When the patient came according to the uh, hospital regulation, Prof. Actually, if he don't have a major complaint uh, during the chemotherapy, Prof. He rarely facing febrile neutropenia and other complications. He always come uh, to the hospital according to the time when the hospital call him.
So he interrupted the chemotherapy often. Is that the conclusion?
Yes, he interrupted due to the the waiting list of the room in the hospital, Prof.
The waiting list on the room. Okay. So the hospital regulations are responsible for this relapse.
Indirectly, Prof. Yes,
The
Prof.
hospital regulations are responsible for his relapse. Oh, wow. Okay, this is already partly answering one of your questions, but let's go on.
Okay.
So
He was
that is in the past. Now look to the future.
yes, Prof. Uh, he's diagnosed with ALL, L1 standard post chemotherapy, and wound dehiscence, reduced scrotum post debridement, and malignant round cell tumor in testis, causabil lymphoblastic lymphoma, and post left orchidectomy on June 2024, and post right orchidectomy on November 2024, with secondary thrombocytosis, uh, with differential diagnosis with infection, with hypertriglyceridemia and overweight and regular height. From medical history, 3 years before hospitalization, the patient was referred from a peripheral hospital due to the recurrent transfusion requirement caused by anemia and thrombocytopenia accompanied by organomegaly, TOF, and multiple cervical lymphadenopathy. And then bone marrow puncture was performed and revealing 74% lymphoblast and a diagnosis of acute lymphoblastic leukemia L1 was established. And the patient commenced chemotherapy on a standardized protocol within 18 days of diagnosis. And a BM and a bone marrow puncture evaluation done on July 23, 2021 indicated complete remission and dysplasia attributed to the therapy after 8 weeks of chemotherapy. But subsequently, bone marrow puncture performed on November 6, 2023 after uh, the complete weeks of chemotherapy demonstrated partial remission of ALL. And then he was prescribed for cyclosporine for the first 3 months following chemotherapy completion and cotrimoxazole as prophylaxis. And then 6 months before hospitalization, the patient present with a painless enlargement of the left testicle and from ultrasonography regular inhomogeneous solid nodule in both testes, raising suspicion of leukemic infiltration. Although no malignant lymphadenopathy was detected. And then consultation with urology department led to the planning of an orchidectomy process. And at that time, his LDH level were elevated at 504, and from histopathology examination following biopsy suggested neuroendocrine carcinoma with differential diagnosis including germ cell tumor and malignant lymphoma. And then a subsequent pathology report on August 2024 confirmed a diagnosis of beta lymphoblastic lymphoma. And then 3 weeks before hospitalization, the patient underwent post-orchidectomy surgery. Initially, his post-operative recovery was satisfactory. However, at home, the surgical wound began to dehiscence without bleeding, progressively worsening over time. And then 5 days before hospitalization, he was brought to Karyadi Hospital for further evaluation and management for the wound. Uh, at the time of examination, from the physical examination, he was alert and no anemic conjunctiva, no enlarged lymph node, no cyanosis, no pill, and liver and lung not palpable, and no enlargement of the testis, and the wound closed by the gauze. This,
Okay, how so? Stop. No enlargement of testis, but he had no testis anymore.
yes, Prof.
And how about the lymph nodes in his groin?
Uh, I don't palpable any
Okay,
palpable
yeah,
lymph node in
still,
his groin.
okay. It's maybe a pity that he was consulted to the urology department.
Yeah.
Yeah. Probably at that point, it might have been better to start, well, to do some more investigations. What do you think I'm aiming at? What, in retrospect, what could have been done in May 2024?
I think maybe to do some investigation, like uh,
Yeah, very good. Yes.
uh, im imaging to uh, to confirm that this is a sign of infiltration of the ALL prof, because from the bone marrow aspiration in the last evaluation, it showed that a partial remission prof, uh,
Yes,
and which
indeed.
and maybe with it can give us another alternative, like chemotherapy prof, for with relapse protocol or high risk protocol prof.
Yes, I agree. Yeah. So at that point, it would have been wise to do another bone marrow puncture and also a lumbar puncture, because in this relapse, testicular relapse, is a relapse in a so-called sanctuary site. Sanctuary sites meaning that the leukemic cells are hiding in a sanctuary, in a church or in a mosque, and the church and the mosque are testicles in boys and meningeal space, intracranial disease in all ALL patients. So the CNS is a sanctuary site, and the testicles are also sanctuary sites that are only reached by, like, high-dose methotrexate. That's why high-dose methotrexate is in the protocol in the first place. Okay, let's go on.
This is the laboratory examination prof, actually from the first time at the May. The leukocyte is around 3,200 with hemoglobin 10.8, and the platelet 18,000 prof. And um, and then uh, pro- along the chemotherapy duration is not more than 10,000 for the leukocyte. Around in May 23, 1,800 in 27
Okay,
May,
well, maybe
and
skip
yes,
over to the diff count and the blood
okay,
smear of May 4th
yes,
at a little bit lower.
yes, Prof. And then from the uh 2024, actually from the
Oh, oh,
laboratory.
oh. No, stop. No, the most important thing to look at in this case is May 4, 2021, the diff count and the blood smear.
Yes, Prof. And the DDIF count in May for the first one, it showed the 5% blood stock. And from the blood smear, we also found blood 5% stock.
Yeah.
And
And what is important, pardon, what is in the diff count of May 4, what strikes you as abnormal apart
uh,
from the blood?
actually, from the first, we have a lymphocytosis, and from the deep count, and the blood AMC metamyelocyte and myelocyte is found. Prof.
Yeah. So you say the lymphocytes increased.
Yes, Prof.
My interpretation is different.
Oh, please enlighten us, Prof.
I will enlighten you. Okay, look at the white blood cell count. What was the white blood cell count?
Yes, Prof.
3,200, right?
Yes,
So this is lower than normal.
yes, Prof. Leukopenia.
Leukopenia. So the lymphocyte 71 is only relative. Absolute lymphocyte count would be about normal. But what is abnormal is segment only 14.
Hmm.
So
Oh, neutropenia, Prof.
neutropenia, yes. So you should have shouted neutropenia, not lymphocytosis.
Yes, Prof.
So 14 segments, 2 metamyelocytes, 4 myelocytes. That is in total 20. And 20% of 3,200 is about 600. So ANC is still about 600, not lower than 500. Okay, so that is a very important part. And then blah, 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 we go further on. Maybe go to the bone marrow punctures.
Yes, Prof. This is a bone marrow puncture impression at the November 7th, from the May 10th, 2021. The first time he diagnosed as ALL, it shows 74% lymphoblast. And on July 23rd, 2023, uh, oh, pardon, Prof. This is 2021.
Yeah, mine was
Yes.
so. I'll change
Uh,
it. I'll change it. Okay. Yeah, so after induction, complete remission.
yes, Prof.
Hooray. Very
Uh,
good.
very good sign for the chemotherapy. But in the November 7, 2023, it show a partial remission of love with lymphoblast 7%, myeloblast 1%, and proerythroblast 1% of
Yeah, so that was at the end of the full therapy.
chemotherapy. Yes, Prof.
My comment here is maybe this was not complete remission, but maybe this was just rebound cells, that is normal precursor B cells, especially after chemotherapy. These cells appear in the bone marrow. So maybe this was relapse, maybe this was just a rebound. In retrospect, now that we know that he got a full-blown relapse, the cytologist, the pathologist, was probably right in giving an impression of partial remission of ALL. Partial remission of ALL also is something to take seriously. So after November 7, probably, if you ask me, I would have advised to do another bone marrow puncture and a lumbar puncture maybe 1 to 3 months later, maybe in January 2024, just to be 100% sure that it is not complete remission.
Mm.
Because suppose you make a false, wrong diagnosis of relapse, then the patient will be treated again for 2 years with the risk of dying from complications, with all the costs and all the worrying about relapse. And if it is not really a relapse, that is overdue. So making a diagnosis of relapse of leukemia or cancer generally, it is very important to be 100% sure that it is indeed relapse and not, as in this case, rebound. Here in this boy, yeah, what happens later? So go on. We see that indeed that must have been partial remission. Yeah, partial remission is like partial pregnancy. You cannot be a little bit pregnant.
Yes, Prof.
You cannot have a little bit leukemia because it will become full-blown leukemia 9 months later. Or maybe even 6 months later. Okay, good. Go ahead.
Okay. And then when he was monitored after chemotherapy, he was done ultrasound sonography of the testes, and both of the right and the left showed there is enlarged size, and the parenchymal texture is coarse and homogeneous. And from the impression, we have bilateral testicular enlargement with coarse parenchyma and the presence of ill divide in homogeneous solid nodule in the right testis and left testis, suspicious for leukemic infiltration, with no evidence of malignant lymphadenopathy in the inguinal regions.
Yeah.
And then he done orchidectomy and biopsy, and do and we got a pathology report finding malignant round cell tumor of the testis with differential diagnosed neuroendocrine carcinoma, germ cell tumor, malignant lymphoma, and from the right testis, we found the pathology report the diagnosis of a malignant round cell tumor in the testis with differential diagnosed non-Hodgkin malignant lymphoma, neuroendocrine tumor. Uh, and the last one, the pathology report from the lab testis showed that is a B lymphoblastic lymphoma. And at this,
Probably the last one was done with immunophenotyping. Is that true?
yes,
Yeah.
absolutely.
Yeah. So small blue round cell tumors are difficult for the pathologist. Of course, if you are the clinician, you should know that in this case, small round cell tumors of the testis is 99.9% certainly leukemia, not neuroendocrine carcinoma, not germ cell tumor, not non-Hodgkin malignant lymphoma. Yeah, if you know the clinical picture, this is 99.9% certainly relapse of leukemia. Maybe the pathologist is looking at the microscope only and not at the history of the patient.
Yes, Prof.
But you as a clinician know the history of your patient, so if you see this, very clear. Fortunately, the last pathology reports, they did also immunostaining, and then you see that these are precursor B cells, CD10 positive, CD19 positive. Okay.
And this is the therapy we give when he is inpatient at this type, supporting and simvastatin. And then this is the chemotherapy regimen standardized Prof, that we use in the past. And for the ancillary, this is a case of 9-year 9-month-old boy diagnosed with ALL1 standardized in May 2021, treated with chemotherapy with initial response as complete remission in July 2021 and partial remission by November 2023. And then in May 2024, he developed painless testicular enlargement with ultrasound findings suggestive of leukemic infiltration. And pathology later confirmed B lymphoblastic lymphoma. He underwent left and right orchidectomy in June and November respectively, And postoperatively, he developed wound adhesion, which requiring hospitalization for further management. And current concern include secondary thrombocytosis, hypertriglycerides, and a history of overweight. And he is on supportive therapy with IV fluid, simvastatin, and dietary adjustment. And this is a problem that we face. So, the first question, what diagnostic and therapeutic approach should be prioritized when testicular abnormalities are detected in pediatric like communicable survivor? And how do these differ from similar presentation in other population, Prof?
Okay, yes, good question. Well, number one, we already discussed in a case like this, relapse of ALL, extramedullary relapse is far on top of the differential diagnosis. That means in this instance, maybe we would have done needle biopsy, but first of all, we would have done bone marrow puncture and lumbar puncture. If there is signs of leukemia in the bone marrow, then you don't need needle biopsy of the testis because the diagnosis is certain. So how do these differ from similar presentations in other populations? Well, if there was no history of leukemia at first, then a germ cell tumor would be number one in the diagnostic list. Although germ cell tumors of the testis are one-sided, and here it is bilateral. The fact that this is bilateral means it is a systemic disease. So it's not probable that the other possible diagnoses like neuroendocrine tumor or germ cell tumor are the correct diagnosis because they would be one-sided.
Prof, may I ask?
Yes.
Sorry, I'm in the polyclinic, so it's not possible to turn on the video.
No problem.
I have a question about the testicular metastatic. My first question, is it possible the patient only have isolated testicular metastasis, but the profile of bone marrow or blood, peripheral blood is still okay, just only isolated in testis? Is it possible?
With standard diagnostics, yes, it is possible because with standard bone marrow puncture results can turn out normal. But if you look with minimal residual disease in testicular relapse, always there are a few leukemic cells in the bone marrow too. So
Okay.
it's maybe not detectable by standard techniques, like if you do a bone marrow puncture, it may come clean, and lumbar puncture may come clean, but if you look with very sensitive techniques, always there are leukemic cells elsewhere in the body. So this is not only testicular, this is always also systemic. So it always needs systemic therapy. Yes.
Yeah.
Good question.
Then my second question. So if the testicular metastasis is always systemic also, so do you think that chemotherapy only is still responsive for that kind condition?
It's possible. Yes, it is possible. Many of the relapse therapies ask for testicular irradiation. Of course, that means that the fertility is gone also. My preference is to use higher amounts of high-dose methotrexate. So to jump to my conclusion, I would treat the patients now. Well, I would do bone marrow puncture and lumbar puncture to check and start the ALL therapy again with one modification. Instead of only methotrexate intrathecal during the maintenance pulses, better to give high-dose methotrexate 3 grams per meter square during the first year of maintenance instead of only intrathecal.
Yeah. So in this patient, or in the case like this patient, maybe, and in my opinion, maybe this patient no need to do orchidectomy. We can just change to the high risk chemotherapy, right?
I agree. Right. Yeah.
Yeah. It was a pity, yeah.
Yeah, it's a pity indeed. And again, looking in the past doesn't change the past, but the fact that he had 24 weeks of delay is a main factor to get relapse. So this is something to discuss in the hospital and say, hey, here we have a patient who had so much delay
Yeah.
because of no availability of beds. What can we do about it? Can we do
Yeah, Prof.
something in daycare?
Yeah.
Can we do something polyclinically? Can we have beds if necessary? So this is something to discuss with hospital management and saying we shouldn't lose patients with a good prognosis ALL due to delay in therapy.
Yeah. That is our big problem. So many
Yeah.
patients relapse because due to there is no bed in the hospital. Do you have ever read the journal or maybe a research about actually how long the patient still can accept the delay of the treatment?
Only if the patient is really, really ill, you can interrupt the treatment. If there is a very low white blood cell count, very low thrombocyte count, like in the protocol, then you know that the treatment is too intense for this patient and you have to half the 6-MP and methotrexate or even stop it if the patient is also sick. But we know that even patients who were having delay in treatment because of good medical reasons, even those patients have a higher risk of relapse.
Okay. For how long, Prof? Is it okay we postpone for 2 week, 3 week, if the condition is not very good, or not be ready for having chemotherapy, such as very low neutrophil count and very low thrombocyte count? Is it okay we postpone the treatment for 2 or 3 weeks?
Yes, you should only restart if the counts have improved. But then, of course, you should ask yourself, is this low counts because of chemotherapy, or is it low counts because of bone marrow infiltration or bone marrow fibrosis or something like that? So that asks for bone marrow puncture in a case like that to exclude that the low counts are due to leukemia. Like in this patient, the first white blood cell count was actually lower than normal. So a plastic type of leukemia, and that is sometimes difficult to differentiate from low counts due to chemotherapy.
Yeah.
Okay.
And
Let me see.
a patient with severe neutropenia, which one better? We postpone a patient for 2 or 3 weeks later and we give fully dose, or we just give the patient chemotherapy but we reduce the dose. Which one better, Prof?
Adjust the dose according to the regulations, to the guidelines with the protocol. So if the counts are below 2000, but more than 1000, half the dose. If the counts
Okay.
are less than 1,000, stop for a week. If there is a problem with the patient, we even would give leucovorin to help the bone marrow recover.
Okay, bro. Yeah.
Yeah, so especially in very low counts, especially if the patient may be a little bit ill, give leucovorin to counter affect the methotrexate.
No. Okay. Okay, bro. Thank you.
Okay. Well, then, Dr. Risa, let's go to your questions. And then your question 2, what evidence-based strategies can be implemented to minimize the risk of relapse in pediatric cancer survivors? Particularly considering individualized factors such as treatment history, genetic predisposition, and lifestyle modifications. Well, for the treatment history, we already discussed if a patient had a lot of delay, the risk of relapse is 4 to 10 times higher than if the patient was able to do all the chemotherapy. Genetic predisposition plays only very minor role in it, but it does. But if you have a genetic predisposition, there's nothing you can do about it.
Yes, Prof.
Yeah, you have it or you don't. Lifestyle modification, not much that influences the relapse of leukemia. The only lifestyle modification you should do is tell the parents to take all the medicines prescribed, not forgetting, because especially in teenagers, they tend to not take the medication. Sometimes they take the tablet and then flush it through the toilet. Especially teenagers are prone to be not compliant. And then your third question, how should clinicians approach decision-making when confronted with two inconclusive conflicting pathology reports? Yeah, that's nice. Particularly in cases where the diagnosis significantly impacts treatment options and prognosis. Yes, sure. Very simple. You are the clinician, you know the patient, so you should know what is the most probable of those diagnoses. In this case, it's very, very clear. The patient had ALL. The patient was not in complete remission at the end of a very long treatment. So the chances of relapse ALL in the testicle were, as we said, 99.9%. Okay, well, thank you for this nice and extensive overview of this boy with testicular relapse after standard risk ALL. And you have good questions too. In your resume, there are a few missing data, the current medication, recent lab, and bone marrow puncture and number puncture.
Yes,
So you can still do that. This is a late, well, semi-late, extramedullary relapse of ALL in a so-called sanctuary site. We discussed it. That always goes with involvement of the bone marrow, as we discussed, sometimes detectable by standard microscopy, sometimes only as minimal residual disease by genetic testing or advanced immunophenotyping. So it's important to give full relapse treatment of ALL, even if you find nothing now in the bone marrow or in the liquor. So irrespective of, but you should still do that because you would like to know whether there is a bone marrow relapse. So my suggestion is to use the ALL 2024 high-risk protocol with the modification of giving high-dose methotrexate during the first year of maintenance instead of only intrathecal. That is to penetrate enough in the testicular remnants in the, yeah. Okay. He can still be cured. Yeah. There's still a chance of final cure of his. So don't despair yet.
Yeah, we still have one case, Prof.
Yeah. So let's go quickly.
Thank
The
you,
case of.
Prof.
Thank you,
Thank you,
Risa.
Rita.
Thank you, Doctor.
Okay, case M, not per.
Who will present the case?
Bu Alfa, Doctor.
Okay.
Doctor, I would like to inform about PER, Prof.
But it's not PER. Oh, something wrong with the
Prof.
sound.
Andrew, Dr. Yeti, and our friend, my friends, with a 12 years old girl, body weight
No,
of
it's not.
29.8
Is it
kilograms, body weight
Dr. Yessi?
139.4
Oh,
Bentar, Dek, dengerin dulu.
centimeters.
Dr. Yessi, can you hear me?
Sorry, Prof.
Hello?
Yes,
Well,
sorry.
my comment is this is not patient PER, but patient MA. So it's wrong in the resume.
The next patient, do you mean?
Yes, this patient. The patient with neuroblastoma. Please present and look at the first 3 letters of your resume. Who is presenting?
Yes. Can
Dr. Alpha.
Okay, Dr.
Yes.
Alpha, where are you? Dr. Alpha Monica. Hello.
can you hear me?
And now I can hear you, but softly.
It's
Yeah.
here, Prof.
Louder, please.
And better to take off your mouth mask. That makes it more clear.
Okay. This time I would like to present a case about a 12 years old 12 years old girl with neuroblastoma, staging T2B and OMO prochemotherapy, post-laparotomy biopsy with anemia, leukopenia, thrombocytopenia, with medical history 9 months before her first hospitalization in March 2024. The child first complained about abdominal pain. The complaint lost about 7 kilograms, and the parents took her to the health center. She also complained about acid reflux. So at first, he was given an medication for the reflux. Next time the complaint did not improve, then she was referred to the hospital, the nearest hospital, and do an ultrasound. And the result was there was a lump in her abdomen, and from time to time the abdomen looked enlarged, and the child was finally diagnosed with suspected tumor. So she was referred to Karyadi. And then at first visit in Karyadi, the girl was referred to the surgeon, pediatric surgeon, to get a biopsy. Later, 5 months in July, the child uh, finally have a surgery and biopsy and have MSCT and advised to second operation to remove the lump. At August 2024, the child first get the chemotherapy and also get MIBG. And now the child is already given the five the uh,
Hey, also MIBG.
fifth cycle of the chemotherapy. I'm sorry, Prof.
You said the patient also received MIBG.
Yes,
Was it
the
for
patient
diagnosis or for therapy?
for diagnosis, Prof,
Okay.
and also for therapy. The patient
what was the result of the
received one.
MIBG scan? Huh?
I'm sorry.
What was the result of the MIBG scan?
The result of the MIBG scan. Wait, Prof. G. At September, the result was. Oh, I'm sorry, Prof. For the first time, it was for therapy for ablation, and for the diagnostic is will be received by the patient on December later, Prof.
Oh, so this was a therapeutic dose of MIBG?
Yes,
That
on
is
September, on last September.
That is very advanced, but you should have you should have a positive diagnostic scan first.
Yes, the patient already have MSCT scan, Prof.
And then my question is, was it positive? Did you see the tumor on the MIBG scan? But if you don't, then therapeutic MIBG is useless. Yeah? If the tumor doesn't take up the
So is
urine.
it actually supposed to be the diagnostic first, then therapeutic, Prof?
Yes, that's supposed. So my question again is, did you get a result of the MIBG scan?
It is not included in the patient. The patient did not have the result, Prof.
Oh, okay. Well, I hope it was positive, and I'm very very enthusiastic about the fact that apparently you can give therapeutic doses of MIBG because that needs very special circumstances. But let's go on first.
Yes,
the
she was given an RAI 131
yeah,
MIBG, and
yes,
then the patient continued the chemotherapy, and until now she already received the fifth dose of the chemotherapy.
okay,
This is the laboratory examination. The blood work shows at first before yesterday the hemoglobin was low, and she was received a transfusion, and then yesterday the result was 12.5. The hemoglobin is increased. This is the CT scan abdomen with contrast. The result was show on May multiple partially conglomerated solid lesion with calcification uh, with within the retroperitoneal region, para-aortal, intra-aortocava, para-cava, right and left para-iliaca communis, perihepatica, right and left bilingual regions, with the size 8 centimeters, urging the gastric and duodenum to the superior anterior, pancreas to the anterior, right kidney to the post inferior, encasing the aorta, inferior vena cava, truncus coleacus, left and right arteries and venous renalis, etc. And there was a thrombus in the inferior vena cava, and the patient today the patient received filgrastim injection because of the low white blood count, and programmed to have a chemotherapy for the five time.
yeah.
She received etoposide and cyclophosphamide today, and the day after tomorrow etoposide, and the day after that etoposide also. This is the protocol. So it is a case of
Yeah. Okay. And then you go to the summary, what you call ancillary, which I would call summary. A 12-year-old, hey boy.
girl. I'm sorry, Prof.
Yeah,
With
I'll
abdominal
change it.
pain
I'll change it for you.
and the complaint was accompanied by a weight loss, and she is already given MIBG, and after the fifth of chemotherapy she will receive the MIBG for diagnostic or evaluation, Prof. At
Yeah,
this time, she has no complaint of cough, runny nose, nor fever or nausea and vomiting.
okay. An interesting case. 12 years is a little bit old for neuroblastoma, but it does occur, no problem. This is retroperitoneal, which also occurs. The fact that this had calcifications is quite typical for neuroblastoma. So yes, probably. Although the pathology, what was it? The MSCT Where do I read? More than supporting the picture of lymphoma, I would say neuroblastoma, yes. And the pathology, malignant round cell tumor, that's always difficult. With metastasis to mesocolon and mesentery, and differential diagnosis of malignant lymphoma and neuroblastoma. So we would like to have the result of immunostaining. No immunostaining of this pathology.
Ada hasil biopsi nggak, Dek?
And urine VMA cannot be done in the hospital presently, I understand.
Yeah.
Well, the clinical picture is fitting with neuroblastoma, so she got the right therapy, and I'm very confused that your radiologist, radiotherapist gives MIBG scan as therapeutic. This is almost unbelievable.
So actually
Okay.
only for diagnostic only, Prof, do you mean?
I think so. That is possible, but then you should have a written result.
Yeah. And the picture maybe.
Yeah.
And the
Yeah.
picture will show the where is the point or the location exactly.
No, it is important to know that it is indeed neuroblastoma.
Okay.
The location you get by CT scan or MRI. MIBG scan is really vague, but this is a patient with a lot of tumor, so that should be very clear. What questions do you have for me? Or would
I
Yep.
actually confused about the MIBG, Prof, because as as far as I know, the MIBG is like we already discussed, that it should be diagnostic first. But it is said that it was for the therapeutic and will be evaluated in the December later in this month. Is it possible only to I mean, is
Depends on
it yeah, depends only on the pathology anatomy and MICT. And my next question, if my curiosity is, what if the diagnostic actually did not show the neuroblastoma cancer?
MIBG scan is positive in about 90%, I think, of neuroblastoma patients. So 10% do not take up the guanidine, which is the active component. But I really have to look up in the literature what about the MIBG scan is, how often it is negative in patients who really have neuroblastoma. Because this is retroperitoneal, in essence, it may be that this is developing into neurofibroma, So sometimes neuroblastomas of this type mature and then they are not malignant anymore. So maybe this girl has a chance to get better and survive. Often vitamin A analogs are given for neuroblastoma. And nowadays we have a new therapeutics that is anti-GD2 antibodies against neuroblastoma, not available in Indonesia, very expensive in Western countries, still a little bit in the test phase, experimental. What you can do is at least give the girl vitamin A in high doses. Might help
That may be
to mature. Yes, say again.
that might be a problem here because the vitamin E is not covered
Vitamin,
by our the national insurance.
vitamin alpha, vitamin A is not insured. All children get it every
E,
6
vitamin
months.
E. I mean vitamin
No,
E.
no, vitamin alpha you should give.
If okay.
Vitamin A, not E.
Oh yeah, I see. Thank you.
Yeah. Okay, well, did we discuss already the doctor's delay in this patient?
I'm sorry.
Did we already discuss the doctor's delay in this patient?
Doctor delay, do you mean?
Yeah, doctor delay between the first presentation and the start of therapy lies about half a year, 6 months.
Half a year.
Yeah. So, well, not much comment, but of course that is not ideal. And then my question is, was there ever a bone marrow puncture done?
The bone marrow puncture has never been done in this patient, Prof.
Okay, in all cases of neuroblastoma, that should be done because extension to the
There
bone
might
marrow,
be
bone marrow involvement of neuroblastoma is quite often occurring.
yes, thank you,
But
Prof.
now she gets the chemotherapy regimen, so suggest to finish the chemotherapy and then wait and see what happens. What are your more questions? Why did you present this patient for discussion?
Yeah. This is Dr. Bambang patient, I think.
Yes, Dr. Yeti, this is Dr. Bambang patient.
Prof.
Yes.
This is the doctor. Did MIBG already answer my question? So I will read the answer of the so this patient for the neuroblastoma patient, they have two program. First for diagnostic and then second for the therapy. If the patient only the diagnostic, so they only give one shoot uptake of the regimen to
Yeah.
MSI. Yeah, MSI. And if the patient continue with the treatment, so the patient will ask for come again every 3 months, and then they will give the reuptake again, but half dose. Yeah, they call this as the treatment.
Interesting. I would be interested to see what you have on paper about the MIBG therapeutic and diagnostic,
Okay.
because as far as I know, iodine for therapeutic is another one than used for therapeutic. So
Yeah.
therapeutic needs very high dose. Diagnostic means only no dose.
Yeah. Yeah. I also wonder why they treat with the lower dose.
Yeah, indeed.
Okay, Prof. We'll ask later.
Okay, maybe one of the residents can send me, because you're so busy. You must be glad that the Congress was finished successfully.
Thank you, Prof.
How many delegates did you have at the Congress?
275.
So very nice, very good. My
Yeah.
compliments. I hope you can rest now a little bit.
Yeah. Yes, Prof.
Okay. I will send my comments with your resume back. Okay. And then
Okay.
see you probably 2 weeks. Now it's 3 plus 14, 17. Yes. Okay.
Okay. Thank you, Prof. See you.
Bye-bye.
Bye-bye.
Bye-bye, Prof.
Thank you,
Bye-bye.
Prof.
Thank you, Professor Bowman.
Thank you, Prof. Sebentar ya, Dek ya. Nanti ditunggu untuk membuat lesson learning-nya ya. Jadi semuanya buat lesson learning 1 kali 24 jam. Harus sudah dikirim ke Prof. Herman. Jadi apapun yang apa namanya? Ini kok eko ya? Kenapa ya? Iya. Ini nanti tolong dibuat apa namanya itu lesson learning 1 kali 24 jam dikirim ke Prof. Anju. Apa aja yang merasa bisa kalian apa namanya dapatkan dari diskusi ini. Terus kemudian untuk presentasi tolong dipersiapkan sebaik-baiknya ya. Tadi banyak sekali presentasi kedua banyak sekali tidak bisa menjawab apa yang ditanyakan Prof. Herman. Pertanyaannya bukan soal pertanyaan konten keilmuan ya, tapi soal data. Soal data aja nggak bisa menjawab gitu ya. Saya sudah tanyakan ke Dokter Gani semua hasil MIBG itu ada di IRM, jadi silakan Anda dibuka. Jangan bilang belum ada datanya. Ya. Untuk 2 minggu lagi nanti yang presentasi silakan Alfa presentasi kembali dengan lebih baik. Kemudian satu lagi yang residen yang mati siapa, Dek? Yesita ya. Nah, nanti 2 minggu lagi Alfa dan Yesita ya. Tolong semuanya dipersiapkan dengan lebih baik ya, Dek ya. Jangan asal membaca aja tapi data-data nggak tahu, pasiennya nggak paham ya. Terus kemudian
Maaf, Dokter.
itu apa namanya? Untuk anamnesis segala macam tuh jangan terlalu panjang kayak gitu, waktunya habis untuk membaca. Prof. Herman tuh sudah memberi template ya. Jadi dia itu untuk anamnesis itu ringkas dan jelas gitu. Jadi jangan terlalu panjang lebar kayak kalian buat di LK kayak gitu ya. Tolong nanti sebelumnya nanti kalau mau dikirim ke beliau dikirim ke saya dulu ya. Oke.
Gitu.
Ya, nanti
Mohon
tolong
maaf, Dokter.
ya kalau kalian ingin menyelesaikan untuk apa namanya lesson learning-nya bisa sekarang ya mumpung masih ingat ya. Ya sudah gitu ya. Silahkan kembali ke tugas masing-masing.
Terima kasih, Dokter.
Terima kasih, Dok.
Semangat semuanya. Di close aja kali ya, Bu. Saya izin kembali ke Bangsal ya, Bu.